Well, hello and welcome, everyone. My name is Dr. Evan Gwilliam, and I have the honor of providing you with some coding and insurance related issue updates on behalf of NCMIC. I'm a longtime member of the NCMIC Speakers Bureau, and so I talk on coding, documentation, compliance, and all that fun stuff. And the purpose of this presentation today is to bring you up to speed with what you need to know to be ready going into the year 2026. So we are recording this at the end of 2025 based upon what we know are the biggest issues, the most important things you got to know to make sure you not only get paid, but you are following the right rules and you are aware of where you might stumble, trying to get ahead of those obstacles and pulling them out of the way. So I want you to be able to start the new year ahead of the curve, not scrambling to catch up. We're going to hit January hard with clean claims and compliant notes and all that good stuff. Now, I am a chiropractor, but I'm also a certified coder and auditor, and that's where my experience comes in. My company, Practice Sync, does third-party billing. So a lot of what I'm sharing with you is the experiences of our clients and the things that I've learned from our billing team that you need to be aware of headed into this next year. I've thrown my email address down there at the bottom. If there's something you want a copy of or reference to, shoot me an email, and I'm happy to provide it. So here are the few things we're going to talk about today. We're going to do the ICD-10 updates that are in place for the year 2026. I'm going to give you some other key ICD-10 tips because there are 3 or 4 ICD-10 issues that we see repeatedly that lead to denials. These aren't new things. These are just a couple of ICD-10 rules that, if you understand them, it can really reduce your error rate and denials and other problems. I have a few payer updates for you. I don't have any huge Medicare changes. There's no big dramatic Medicare overhaul that you need to be aware of, but there are a few Medicare rules to remind you of. But I do have some big changes to a few big payers that you should pay attention to in case they affect your patient base. And then I want to address briefly the concept of E&M denials on the same day as CMT services, which I'll explain more when we get there. I have some great tips and tricks for you to reduce those and kind of play the game of the payers so that you get it done. And then I want to discuss the Medicare fee schedule a little bit because that is something that changes every year. And I want you to know what that means for you and what you need to do to pay attention to it. So I don't have any CPT code changes to talk to you about because I don't believe there are any that are that big a deal, except for one exception, which I didn't include here in the presentation, but I'll talk about for just a minute. And those are the codes for remote monitoring. If you do remote monitoring, they added 2 new codes for shorter durations. And so it's 2 to 15 days, and the code's 99445, and then another code for treatment management is 99470. I believe these have been finalized. Last I looked, they were proposed, but I think they may have been finalized. And the idea is to improve flexibility and expand reimbursement for short-term monitoring with these types of devices. If you have questions about that, shoot me an email and I'll send you the information that I have. But my understanding is that's not real common amongst most chiros. So just know that was the only CPT code change that I think you should be aware of. Having said that, I want to shift to the ICD-10 code changes because there's always quite a few updates every year. And sometimes there's more that affect chiros and physical medicine providers, and some years there's less. So the official ICD-10 code updates, which are your diagnosis codes that used to describe your patient's problems, the conditions that they're seeking treatment for, those changes went into effect October 1st of 2025. So the calendar year isn't what applies for ICD-10. It's October 1st to October 1st of the next year. So if you're watching this recording in January of 2026, you should know those codes changed 3 months ago, and you're a little behind the curve. And these are used for patient encounters based upon patient encounters, not on the date of claim submission, but the date of the patient encounter. So the changes that are relevant to chiropractic, honestly, are few, but there are some that might apply, and those are symptom codes, and there are a few codes that discuss socioeconomic status, and I'll explain the value of those codes as well. So those are the things to keep in mind. We're going to start with a few symptom codes that change, and I want to show you those codes, and you can kind of be the judge if you think they're relevant to the type of care you provide or the types of patients you see. The codes we're about to look at are in Chapter 18 of ICD-10, and these are all codes that start with the letter R. The title of that chapter is Symptoms, Signs, and Abnormal Clinical Laboratory Findings that are not elsewhere classified. The instructions in this chapter tell us that symptoms and signs, as opposed to diagnoses, which are an actual condition, are acceptable for reporting purposes when a related definitive diagnosis has not been established or confirmed by the provider. So you only use these when you don't have something better. Okay, and that's why I say use these with caution. They are a weaker justification for treatment. They're not nearly as solid as an actual condition where you describe something. So keep that in mind as we discuss these codes. What I'd like to do is show you the actual file where they tell us and describe to us what's changed. So what I brought up here for you to look at is just a PDF file. You can download this yourself, or if you really want a copy of it, email me and I'll send it to you. It's 48 pages long, and it's the addenda that describes the changes that went into effect October 1st of 2025, or for most of the calendar year for 2026. And what I do every year is I get a hold of this as soon as it's available, and I scroll all the way through and look for anything I think is relevant to chiropractors. So in this case, we can skip all the way down to page 31 before I believe there's something that really matters to a chiropractor. And I've highlighted it here to make it easier to understand. And it's in chapter 18, which is the signs and symptoms. So these are not conditions. These are descriptions of conditions of symptoms that patients are complaining of. So prior to this change, there was a code. There's a category R10, which is abdominal and pelvic pain. Okay, and they added R10, 20, 21, 22, 23, and 24. And you'll notice it's just more specific locations where this pain could be described. So if a patient is being seen by you and they say that they have pelvic and perineal pain on the left side, then now you have a better code to describe that. Before, you could just say pelvic pain and perineal pain. You couldn't say which side. So just take note. These are a little bit more detailed. These are slightly better codes for you to choose from to describe that type of pain. And that's really all you need to know about those changes. But it's useful to get a little more detail, right? They also added a code for abdominal pain of multiple sites. There was already codes for abdominal pain, but they only described single sites. So now you can say multiple sites. Now, they also added some excludes one rules around this code. I'm going to explain this more in a moment with other examples, but this is one of the key ICD-10 rules that doctors don't fully understand sometimes, and it leads to not getting paid. Basically, excludes one means that if you use one of these other codes in this list right here, you're not allowed to use this new code. You can use either or. Excludes one means mutually exclusive. So you can't have abdominal pain in multiple sites and abdominal rigidity. The rules don't allow you to report those together. Okay, that's what excludes one means. More new codes include flank tenderness, and we've got right, left, suprapubic, and unspecified location. So here's another tip for you. Imagine a patient comes in and says, "I've got pain, in the flank region," and you don't ask if it's right, left, or suprapubic. That sounds to me like you're a provider who doesn't really do a great job, and you should not be reporting R10.8A9 because that means you didn't say where it was, and that's just bad form. So avoid these unspecified codes when they describe a location, or rather fail to describe a location. They also added this group of codes for pain localized to the flank. Here's another rule for you to consider. See beneath the code, there's these other descriptions. These are called inclusion terms. And inclusion terms are also described with this code. So if you don't say pain localized to flank, but you say lattice region pain, this is the right code. That's what it means if it appears underneath the code. It's an inclusion term. Right? Now this one has some excludes too. Excludes 2 means you could report these in addition. In fact, you need to understand that these codes here are not included in these codes here. So you'd have to report them if these are present as well. And so excludes 2 means not included, and excludes 1 was mutually exclusive. Okay. So here's the new codes: flank pain, right, left, bilateral, and there's an unspecified, but I would stay away from it if I were you. So those are the changes to some of the symptom codes that might affect chiropractors. You'll notice those are like, well, do we see a ton of flank pain and abdominal pain? I don't know if we see a ton, but we see it. So it's good to know that those codes are there now, and we have that information. Okay. So let's move on then to some other changes. The only other changes, significant ones I found in ICD-10 that I thought might be relevant to chiropractors there are a few in chapter 21, which are Z codes. So Z codes are the last chapter of ICD-10, and they describe reasons for encounters and factors influencing health status. So they are not conditions. They don't explain a disease or an injury. They explain the reason for an encounter, and they talk about health status. So the section we're looking at is Z55 to Z65, where they made the changes, and they talk about persons with socioeconomic or psychosocial circumstances. So what we call those in other terms is social determinants of health. Now, this is a great buzzword because social determinants of health are factors that can affect the patient's risk of response to care because they don't have, shelter or food or that sort of thing. And it relates to evaluation and management codes. And so that's where this might be relevant to you. If you happen to feel like you can justify a level 4 E&M code, which is pretty high, it means it's a serious case. One of the factors that helps get it there is if you report a social determinant of health, and these newer codes or these changes to the codes make it easier to report that information right on a claim form with a code instead of just documenting it. You should document it, but you can also now report it with these codes. I mean, the codes have been around, but what they've done is expanded them a little bit. So let me show you these changes. I'm going to keep scrolling down through the list of changes in ICD-10, and you can see here, oh, well, actually, this one's a side note. There's also some new codes about types of activities where you can be injured. Y codes are all about activities. And if a patient comes in and says, I was splitting wood and that's how I got hurt, you could potentially report this code. External cause codes like this are optional, but I like them. I think they're a great way to tell more information on your claim form. There's lots of great codes there. You don't have to report them at all if they're not really, you don't understand them, or you're not comfortable with them. But man, imagine if you could tell a reviewer that this is why they came to see you, is because they hurt themselves doing this, instead of having to have them request your records and wait for payment and send that in. Now, we are now in the section I was just talking about with the Z codes, which is socioeconomic and psychosocial factors that affect health. And so what's going on here is the codes themselves are all still there, but they've added some inclusion terms. So if your patient says, the real reason I'm here is because I have workplace stress, or I've been furloughed or underemployed, see, they used to have this code that said other problems, but they added these extra descriptors, which makes it more specific. So that's kind of nice to know. Homelessness, like unsheltered homelessness or lives in a homeless encampment, either of those would work for Z5902. And that is a social determinant of health. And it may justify why your patient needs more care. Poor housing weatherization, you can report that if it's relevant. These are kind of interesting. Financial insecurity, that's a new code. And they added all these specifics about patient unable to, have a safe home environment. Bankruptcy, you're able to say this one's brand new too. And so bankruptcy, there's code to report that if that's an issue relating to the patient's health and why they're seeing you. So I just wanted you to see these codes and understand these options. You don't have to use Z codes, but I think that they can also be a great way to tell the story and give a little bit more background to why your patient is being seen, perhaps needing an exam and that sort of thing, which I'll talk about that a little bit more too. So just to review some key ICD-10 coding reminders, these are not new. These are just rules that can lead to problems if they're not followed very well. Excludes one, when you see that under a code, it means you can't use those codes together. They're mutually exclusive. An example of that might be, here's a condition that I was born with, and here's a condition I acquired later, like loss of a limb. You can't report both. It either was born that way, or it happened later in life. Those are excludes one. Excludes two means, hey, the code you're looking at does not include this other thing. So if you want to say that it's there, you need to report these excludes two. Okay, so keep that in mind. Excludes one, if you ignore that rule and you report codes that don't belong together, will lead to denial. So we can also see this abbreviation NOS. It means not otherwise specified. And it also is synonymous with the term unspecified. And you may have heard this before when you learned about ICD-10. If a code says unspecified in its descriptor, that means you did not document something that you may have been able to find and use a better code. So I would discourage you from using codes that have unspecified or NOS in their descriptor. Or only use it as a last resort, because it shows a lack of specificity in your records, essentially. In some cases, they are appropriate, but only use them if there's nothing better to be found. And then I want to talk about diagnosis pointing, which I will get into in a minute as well. I'll show you an example. This is so critical. Once you learn how to do diagnosis pointing, if you're unfamiliar with it, it can save you a lot of headache. It gets you out in front of a lot of reasons for claim denials. Okay, so we're going to talk about box 24E on the CMS 1500 claim form. I'll show it to you in just a minute. But first, a couple more examples for excludes one, just to illustrate this point. If you were to report this code, and this code was new like 2 or 3 years ago, M5450, it has excludes ones for these 3 codes. That means that if you report M5450 for low back pain and you report low back strain, which is S39.012A usually, then your claim will be denied because those codes cannot be reported together. And if you stop and think about it, it makes sense. If someone has a low back strain, you don't have to report low back pain. Of course, their low back has pain in it, right? And then these other codes have the word lumbago right in their descriptor. So lumbago is redundant with low back pain, so you can't report these codes along with that either. One more example, just to bring this point home. M54.6 is pain in the thoracic spine. It has an exclusion with thoracic disc disorders that also have pain, which are found in M51s. This one's a little weird because M51s also include lumbar disc problems. So technically, according to this rule, which I think is messed up, you can't report lumbar disc and thoracic pain because lumbar discs are also M51s. So that's an example of how these excludes one apply. And if you're ever in doubt, you can Google these codes and look them up. They're available in the public domain. They're free. And just look at the excludes one, and that means you can't use them together. Okay? Email me if you get lost on that too, and I'm happy to help you out and answer those questions. And then the last diagnosis code tip I really want to discuss, which I think is the most important, and again, not new for 2026, just something that can reduce errors and lack of payment, is to try to tell the story on your claim form. This is a close-up shot of the bottom half kind of the CMS 1500 claim form. And I want you to look at what I've listed here in yellow. It's the code 98943. That is the code for extraspinal manipulation. Okay, and extraspinal manipulation is not done on the spine by its very definition. It is extraspinal. So it has to be, shoulder and beyond, or hip and beyond, or base of the skull, beyond base of the skull. Well, I'm looking at this sample claim. This is a real claim I had with a client, and they were like, why am I getting denials? If you look at the yellow diagnoses that it is linked to, because this column right here is the diagnosis pointer column on the claim form, and it's saying, I did this procedure for these diagnoses to treat these conditions. And if you look up at BCD, the ones that are up here in yellow, they are all spinal codes. Those are codes for spinal problems. So what you're saying to the payer is, I did extraspinal manipulation on the spine. It should have linked to only A. A is an extraspinal code, and that would have been fine. But likewise, if you look at the blue 98941 right here, it was linked to A, and it shouldn't have, because that is not the spine. And this is a spinal code. That's spinal manipulation. So take the extra time. A lot of software defaults and puts in A, B, C, D. You need to take a few moments to correct those specifically for each patient with each procedure that you perform. Most software, once you've done that, will carry that forward. If you have to redo it every encounter, that's a real pain, and you should look into better software, in my opinion. But diagnosis pointing is an easy fix. It's just logical. You need to make sure the procedures that you describe also match the diagnoses that explain the reason for those procedures. Okay, so that is a golden nugget for you if you weren't aware of it before. I did want to briefly talk to you about ICD-11. We've had ICD-10 in place since 2015. So at the time of this recording, that's 10 years. It took a long time for us to get to ICD-10, and it's going to take us a while to get to ICD-11, but you should know that it's been available since 2019, and it was implemented worldwide in 2022, not for healthcare transactions in the US, but for things like death certificates and statistics for global health. So ICD-11 is a code set that's being used and has been used around the world for various purposes, just not for use in the US yet. They've said it could come into play as early as 2027. So get ready. It differs from ICD-10 primarily because it's digital first. It's designed to be seamlessly connected to EHR software and integrated. It's also available in multiple languages, so they've made it so it's internationally friendly. There's also ways to report more detail and accuracy through something called post-coordination and clustering. And And so there's these additional concepts that make it more clear. And it has expanded scope to cover things like traditional medicine, social determinants of health, more mental and neurodevelopmental disorders, things like that. So stay tuned for ICD-11. We'll do a whole webinar on it when the time comes and get you ready. But maybe as early as 2027. So it's coming. And it's going to be better, supposedly. I haven't looked really close at it, but just stay tuned. So that's your diagnosis code stuff. Here are some specific things you need to do in general if you're doing any insurance payer work. This is some things I would encourage you to do to get ready for 2026. Billing compliance and network attestation is very important. Providers should regularly attest and verify their data for different entities. For example, CAQH that you may need to do for your credentialing, Availity, ASH network if you participate with them, Medicare and PICOS, their enrollment system, Medicaid, there are other payers. If you fail to complete attestations saying that everything is still the same or you haven't been sued for fraud and your address is the same and you've done all that, if you fail to do that, you might get removed from the network and kicked off the plan and kicked out of the payer directory. So I very highly recommend that you use this end of year time to always review all of your agreements and networks and make sure they're up to date and accurate. That'll prevent disruptions in billing and claims processing in the next year. And it should be an annual exercise. Okay, let's talk about Medicare for a minute. If you are dealing with Medicare Part B, not Medicare Advantage, which is a separate deal, you should get up to date on the deductible. It's going to kick in January for all your patients with straight Medicare Part B. The deductible is changing to $283 for 2026. So be aware of that. And if you see patients with Medicare at the beginning of the year, you might be the one who needs to collect on the deductible. So you should also obtain updated copies of the patient's Medicare cards, even if you have a copy of them from the previous years. You should also get copies of any supplemental or secondary insurance cards because you really need to verify two things. First, is Medicare Part B, they're still their primary and active payer? You got to make sure they didn't transition over to a Medicare Advantage plan, because if they did, you can't bill Medicare Part B. You have to bill that other plan, which is through a private payer typically. And then second, you need to make sure, you need to find out if their supplemental or their secondary payers will cover the deductible if you're going into the beginning of the year. That kind of proactive verification can help manage patients' expectations so they know what they're paying out of pocket and also prevent unexpected billing issues. Okay, those are really critical at the beginning of the year. Here's a couple things that changed with some specific payers. So again, I don't know if these are payers that are important to you, but let me tell you what's going on. Cigna, their Med Advantage plan is transitioning to something called HealthSpring. So there was a network buyout and Cigna Medicare Advantage network is transitioning to HealthSpring. This change may necessitate new provider enrollment for existing and or new products that are becoming available in January of 2026. Providers need to proactively investigate if they need to complete new enrollment processes to continue serving these patients and ensure uninterrupted billing. All right, so that's Cigna. Humana is undergoing a large-scale network restructuring. This mostly impacts Florida, but also it's pretty notable in a few other states. So this could lead to providers receiving like a lack of payment with an explanation, termination without cause. Which means you didn't get set up in the new network, so you're out. So conversely, a lot of commercial networks in Florida and other regions are also adding a lot of new plans, Medicare Advantage and commercial plans, partially in response to these changes, but also just some industry updates. So providers should verify the existing enrollments with these and consider enrolling in new plans and being added to their networks in January 2026. Being a network contracted provider doesn't automatically grandfather or guarantee new plans or adding you to their existing contracts. So you need to be active on this. If you feel like that's a lot of information and credentialing is overwhelming to you, there are third parties out there who will provide help and handle this for you for a fee. There's one I've worked with called Rapid Credentialing, for example, and they'll help you figure all this out and manage all the ins and outs. Or you can navigate it and try to figure it out yourself once you see which plans are active in your area. So get in front of that, and that will prevent headaches down the line. Okay. Okay, I've got a few more tips for you. One of the big issues in chiropractic that's been rising up the last year or two is denials for exams performed at the same day as a chiropractic manipulative treatment. Here's the deal. Chiropractic manipulative treatment is, the way the code is described, it's kind of like a pie. All right. And when I go to purchase a pie, let's say the pie is $15 and I just got a pumpkin pie, $15. Well, chiropractic manipulative treatment isn't just a pumpkin pie. It's like a pumpkin pie that has this extra layer of crust down the middle, and the other half of it is also pecan pie. So it's like a one pie with multiple flavors built into that pie. And that pie, even though it has multiple flavors, is still $15. So if you perform an exam at the same encounter as chiropractic manipulative treatment, you're buying a pie, or you're getting paid for a pie that has multiple flavors in it. And it's just $15. However, if you say, no, I want a pumpkin pie and a pecan pie, I want two pies, that's $30. You need to make that clear. And payers are cracking down on this. They are finding all kinds of excuses to bundle E&M into chiropractic manipulation. And the way that we are told to separate them out is to use the 2.5 modifier. And what happens is you use the 2.5 modifier and they say, yeah, but you didn't use it correctly, so we're still denying and bundling it. And so I've got here for you 8 tips, 8 really good tips that I've researched very carefully, and I've got references to back these up. If you use just a few of these, but hopefully all of them, I promise you that I'm not going to promise you're going to get paid for your exam on the same day, but I promise you your odds of getting paid are much higher. This makes it much, much harder for them to claim you're using the 2.5 modifier incorrectly and that it should be bundled in. Here are the tricks. Number 1, link the E&M code to a different diagnosis code than the chiropractic adjustment is linked to. That says that you're doing the exam for something other than evaluating that the patient needs to be adjusted, because the evaluation that they need to be adjusted is part of the adjustment code, the 989401 or 2. Number 2, document a new condition or exacerbation if present. That often justifies the need for a new exam. If the patient has a new complaint, they've got a serious exacerbation, that can often be great medical necessity cause for justifying a separate exam. Number 3, if you clearly document that you have a care plan and you're doing a phase of care and then you end a phase of care and you need to start a new one, that can also show the need for a re-exam. So it's not just routine. It's, I set up a plan, I finished it, and I'm kind of deciding if I need a new plan. You have to show that you need a full exam to make that decision. And if you document that kind of information by saying you did a trial period of care and not just, I'm planning to examine them every 4 weeks forever, that makes it more clear why that exam is necessary. Number 4, link the exam to an external cause or an encounter code if relevant. So an external cause code is something like patient was, fell out of a tree. Those are those external cause codes start with V, W, X, or Y. And I showed you a couple of them earlier. If you link to one of these, you're saying something new happened, causing a new problem, and it warrants a new exam. External cause codes are not required. They're just available. And there's lots of interesting ones, like bitten by a walrus and being struck by a tornado and things like that. But they're interesting, and find one that describes what's going on with your patient. And it can help justify, if you link it to the exam and not to the CMT code, it'll show that that's why you did the exam. Okay, number 5, when you perform the exam, do blood pressure, orthoneuros, talk about differential diagnoses, talk about your plans for services that are not the CMT. All of those things are not related to CMT, and it shows why and how the E&M is separate from the CMT. So to take that even a step further, step number 6 is actually my number 1 best tip in here. Number 6, 2 separate notes. If you want to do an exam the same day as CMT or an adjustment, then give it its own page that says this is the exam. Only document things on that page that are not on the other page, where you document only the things necessary to prove the patient needs to be adjusted that day. Those, if you keep those totally separate, you have the 2.5 modifier, it's crystal clear that those services are separately reimbursable. Okay. You can make it a little easier on the reader too for step 7 if you use the words significant and separately identifiable to describe the exam, because this is the definition of the 2.5 modifier. So the 2.5 modifier means this is significant and separately identifiable. So you're saying, I don't have one pie with lots of stuff in it. I have 2 pies here. And you use the words that the coder is familiar with and looking for. And then number 8 is similar to number 6. It's in your records say, okay, I'm doing the exam. I did it from 1:41 p.m. to 1:59 p.m. And then at 2 p.m. exactly, I began to do the CMT. So you're separating them out. You're saying, this is the exam. This is the adjustment. There's no overlap. We're not doing a little bit of each all throughout. We do this, we end it, and we do the other one. And those kinds of things will help separate it out. One way you can do that, again, is by documenting the actual start and stop times of those procedures. So those are some great tips to increase the odds of you being able to get paid for a re-exam. I actually have a 1-hour presentation just on this that gets into deeper details and gives you sample codes and all that stuff. But I wanted to give you the tips and tricks to get you right to it today. So one thing you may have caught is the problem here is that they bundle them together if they're done in the same encounter at the same day. And so one way you can avoid all of this is to simply not do your exam the same day as an adjustment. However, I think you run into ethical concerns about doing that if it's just so you can get reimbursed more, right? You have to have good rationale, like clinical reason, and or you could try to rationalize that it's because the payer has rules and you can disclose to the patient in their intake form. By the way, in our office, we do an exam on a day where we don't do adjustments. Maybe you only do exams on Tuesdays and you don't do adjustments on Tuesdays, but you explain to the patient, we have to do this in order to deal with the coding rules that are implemented by your insurance company. And so that's why. Whether or not that would stand up in court, I don't know, but you can explain the reasoning and do your best. So that's kind of the nuclear option, to do it on a different day. So anyway, that's the E&M stuff. Again, I could talk about this a lot more, but I wanted to give you the best, the top tips for that. So just a few more things for you to take away and into the new year. I sort of hinted at this already, but I want to make sure you're clear on this. Good tips to keep you from having slowdown in your payment in the beginning of the year is patients come in for the first time of the year, get new copies of their insurance cards every year. And then re-verify all their benefits every year for every patient. It's tedious, but man, when you verify benefits, it sure prevents a lot of errors. Even if it's the same plan as last year, the coverage could change. So you should re-verify benefits and document that so you have that information. 3, evaluate your fees and check them against Medicare. That's the last thing I'm going to show you, and I'll get to it in just a minute, how to find the fees on Medicare's physician fee schedule. Number 4, you should, as I mentioned earlier, double check your credentialing and re-enrollment. Make sure that the plans haven't changed and shifted out from under you or switched to new names and all that. You'll have to verify those. And then another tip I have for you to smooth down your billing process is to go for electronic claims. Electronic claims can make sure the errors get caught quicker. They transmit faster. We get a response faster. As someone who helps run a billing service, I can tell you they make our jobs far, far simpler. My team that does all the billing, they love electronic claims, paper claims. We can do them, but they're just tedious and they're slower and they're less efficient. So if you have the option to have electronic claims, you're not using it on all your payers, you should be. Okay, and those will make things slicker for you. So this last, I think it's the last thing I want to share with you. It's the physician fee schedule. I'm actually going to bring up the website and show you a couple of things here. So if you're looking for this, just type in a browser, CMS physician fee schedule, or you might even be able to do Medicare physician fee schedule or MPFS, and it'll take you to this page. And so what you do is you scroll down to this page, you say accept, okay? And now I'm on the fee schedule page and I'm looking at the year 2025. Now what I want you to do is select 2026 if it's not there. At the time I'm recording this, the 2026 fee schedule has not been released. It usually is released in January, but it actually depends on politics and approvals and Medicare budgets and things. So sometimes they delay it or they release it and then they modify it later. As you can see, there are 2 of them for 2024. So what I'm showing you right now is 2025. But I'm encouraging you to go in and make sure it's 2026. Okay, it's just not there yet. And what you can do is come in here and say, I want to see what the Medicare fee is for 98940 through 98942. Those are the 3 codes Medicare covers. And you can also come in here and specify your locality. So let's say you're in, well, it looks like I have San Francisco there. So let's say you're in San Francisco. You can type it in and search, and it gives you fees that are geographically specific because Medicare reimburses differently depending on the cost of doing business wherever you are. So what we get is this table, which I can export or whatever, but what I want to point out to you is this column right here, the non-facility price. This is for the San Francisco area, how much Medicare pays in 2025. What you're going to see is what they're going to pay in 2026. And word on the street, I think, is that the price is actually going to go down a little bit, but stay tuned. I'm not sure. I think there was something about them adjusting it up and then also down, and the net change was going to be down, like 2 opposing factors. But this is the Medicare fee schedule if you are a PAR provider. if you are a non-par provider, that fee is over here, but you are a non-facility because you're not in a hospital, and these are the dollar amounts. And so I want you to go in and look at those and compare your fees and make sure you have them lined up and update your software. That's another tip for you, is to update your software if it allows you to track this, and put in those fees as soon as you know them so that you're billing the right amount and your records reflect that. You can also, just for fun, search other codes in here. For example, we could go in here and look at 97110, which is therapeutic exercise. And if we search for that, we see what Medicare pays for that. But what's interesting about that is I know Medicare doesn't pay chiropractors for this code, but we see the dollar amount, and it helps us see how it compares to the codes we do know, which was the 98940, 98941, and we can help look at our fees and try to keep them proportionate. Okay, and there's a longer discussion there to be had about how your fees can compare to Medicare, even though Medicare doesn't pay for this to chiropractors. But I wanted you to see that you can get in here and really dig around and get some great information. So that is where you can see how Medicare has changed the fees right away at the beginning of the year for your locality. Okay, so that is that's my last tip for you. That was a lot of stuff. I went kind of all over the place. What I'm trying to do is help you get ready for 2026 and hit the ground running. I don't want you to be scrambling to catch up. I want you to be ahead of the curve. And if you can get these things done during the slower period through December, during the holidays, and do some of this digging and get the information get out in front of your credentialing and the fees and so on, you'll be much more prepared for a smoother year in 2026. You're more likely to bill properly, get paid for what you're doing, avoid the obstacles, and move forward being reimbursed, hopefully, fairly for the work that you're doing, and help more patients and reduce your risk and live happily ever after. So I am Dr. Evan Gwilliam. Again, I'm Senior Vice President of Practice Inc. There's my email address at the bottom of your screen. Feel free to reach out to me if you're watching this later in the year and you have a follow-up question. I'll do my best to send you the right place. I want to thank NCMIC for allowing me to get this information out to you and putting this information out into the world. So thanks so much. Good luck in 2026. You got this.